So, welcome to Bilmed Ultrasound Training Institute. This is not a training course, as you already know. This is a question and answer session for our ongoing registered candidates. So we are having many candidates who are undergoing different online server-based courses. We are today taking a question and answer session for those. So this is not a course right now. Whatever we are taking question and answer session. So the format, most of you are knowing that we have got some questions, many questions rather, from our registered candidates. I'm displaying the list of these questions. The first question is a case-based question. So I will show the case also, which has been posted by our registered candidate. And the second is also machine settings, I will say an inquiry or a case. And the third, as you can see, is that, sir, it is posted by Dr. Durgesh. First one is by Dr. Nupur, and before that, it was the Dr. Swati who had posted that case, which we will show you what was the case. And now Dr. Durgesh is posting, sir, you said that yolk-sac is diagnostic of intrauterine pregnancy. But in this picture, in which picture I will show you, the confusion arises in this picture. Which picture I will show? It is ectopic. Difference between ring sign. Second question, difference between a ring sign and blob sign. Please explain the pseudo gestational sacs. So there are actually 3 to 4 questions posted by Dr. Durgesh, which I will elaborate in detail. Dr. Rishi Kumar is posting, is ductus venosus mandatory for NT scan? I'm summing up the question. It means that do we have to take an NT scan whenever we are taking an NT scan? Is it mandatory to take the ductus venosus first? Second is that if so, in between 11 to 14 weeks, which time it should be checked? I could not make out ductus venosus flow. So these are the copy pasted questions. What I mean by copy pasted, this the language is original as we got the question, so we copied and pasted. So that is why you can even make out that the language even is original. And then lastly, the Pankaj Gupta, Dr. Pankaj Gupta is posting another case which we will discuss today. So the point is that we will take these questions for sure. But first of all, I would like to hear from you. I would like to hear from you. If you are having any questions, you can raise the hand, not the physical hand, not this hand you have to raise. There is an option in more. There are 3 dots. The more option is there, and you have to click on that more option, and a pop-up will appear saying raise hand. So this is the digital hand, not this physical hand which you have to raise. So the more option is there. In more option, there is an option of raise hand. So you can click over there, but please make a note, if you are having some background noise, please don't raise your hand, because your background noise will disturb whole of the class. So please don't raise hand. If you are having a background noise, please refrain raising the hand. Again, this is not the hand which you have to raise. You have to go in the more option, and there is the hand raise option which you have to raise to pose your question. So anybody can come forward for any questions. If you are having any questions, you can raise your hand, and I will unmute your system distantly from our side, from our software, and we will be taking your question. Give me a headphone. Who is this, Shreya Raj? Not you, no? There is one Shreya Raj. I am unmuting Dr. Shreya Raj.
Hello.
Yes, ma'am.
Hello. Yeah, good evening, sir.
Good
Sir,
evening.
I wanted to know about the knobs that are mentioned as P1, P2, P3 on the machine. Can you please elaborate on those buttons also?
P1, P2. There are some knobs in your machine. Dr. Shreya wants to elaborate the knobs over there. There is one class in machine settings. I
Yes,
mean,
sir.
physics and machine settings course, there is one dedicated class of about 40 to 50 minutes, which is explaining each and every knob. Now, I don't know which knob you are talking of right now to discuss with me. Neither you are sitting on machine, nor I am having machine in front of me. But what I can make out, you are talking of the right side corner and you are using probably a G machine. Is it so?
Yes, sir. Right.
Yeah, there is P1, P2, and P3. So P1 will be for storage, P2 will be for printing, and P3 will be for, I'm recalling from a G, maybe that this machine is a P3 or P4. Yes?
P3, sir.
P3. So I'm recalling from my memory. Now see, the point is that not everything I will be knowing precisely which machines, which knob will work for what. Because it is like a mobile phone. If you are upgrading your mobile phone, you are getting multiple knobs, different knobs. You have to yourself see for which knob is working for what. P1 will be working in G machines, in logic P3 and P5, it will be working for printing purposes, direct printing without pressing onto the Sony thermal printer, and P2 will be for saving an image. The most important point is that you have to see the knobs which you are not, what I mean, which the knobs which are on the upper part of your control panel next to your display. These are multifunctional knobs. You have to see to these multifunctional knobs, and you have to see for the frequency, the dynamic range, which is each and everything is discussed in that machine settings class of 40 to 50 minutes. I strongly recommend you to go through that class again.
Yes.
So,
yes.
Yeah. Any more questions you are having?
No, sir. Thank you.
Yeah, please mute yourself. Next. Yeah, next, please. If you are having any question, any candidate. Okay, now let us go to today's questions. Now see, I am already having a list of these questions with me. The first question is case-based. This is the case-based question. Now, I will go to one question that is posted by Dr. Rishi. Is ductus venosus mandatory in NT scan? Now, the point is you have to understand what for you are taking a ductus venosus flow in a early pregnancy, I mean in a NT scan. What for you are taking? Are you taking this NT scan in level 1 to rule out or to see for any fetal acidosis? Yes or no? Think. Whosoever is thinking yes is wrong. We are not taking ductus venosus in NT scan to see for any fetal hypoxia or any acidosis. Big no. What for we are taking the ductus venosus flow in NT scan? To see if there are any suspicious rather of any cardiac abnormality or any chromosomal abnormality. Why? Because if you will be having an abnormal ductus venosus in an NT scan, in level 1 scan, if there is an absent or a reversal component in ductus venosus, that is giving you a signal that, doctor, there may be a heart defect, there may be a chromosomal abnormality. So the first part of question is that what for we are taking this ductus venosus in NT scan is not to see for any hypoxia or acidosis, but to see for any chromosomal abnormalities. But in third trimester, the same ductus venosus is for fetal acidosis or any hypoxia, which we will discuss in fetal color Doppler in great detail. So the second part of the question posted by Dr. Rishi is that If so, is between 11 to 14 weeks? Yes, it is in between 11 to 14 weeks. Not after 14 weeks, you are taking the NT scan. Whenever you are taking an NT scan, take ductus venosus also. Third part of the question is that I am not making out ductus venosus flow. This is posted by Dr. Rishi. Now see, I told you what you have to do. You have to see that the fetus is in sagittal section, complete mid sagittal section. Unless and until, how to take that? That is part of our course. But again, I am repeating, unless and until your fetus is not in complete mid sagittal section, do whatever you want, but you cannot take, you will not take a ductus venosus. You will not hit to the ductus venosus. Why? Because where is ductus venosus? Let me stand. Now see, where is ductus venosus? A bit. Yeah, hold on. Now see, where is ductus venosus? Ductus venosus is in the center, It is somewhere here. It is at the level of the above umbilicus somewhere here. But the point is, it is in the center. What to do to cut this part? Which section to take? Which section you will be taking to cut this part where the ductus venosus is? And that is not the transverse section. That is not a coronal section. That is a complete mid-sagittal section. I am repeating for the fourth time now. Not only mid-sagittal section, a complete mid-sagittal section, because in sagittal sections, we do have parasagittal sections also. But the ductus venosus will be seen in complete mid-sagittal section. Now, my question to you, you have to more think when you are doing ultrasound. Not doing will do, but thinking will do. But the point is, what you will hit. The point is, what else you will hit if you are in complete mid-sagittal section. Don't you see the fetal nasal tip? Because in same section, now see, because in same section, whenever I am cutting through the ductus venosus, I am automatically cutting through the fetal nose as well as the NT, your favorite one, NT. So the point is, in which section you are taking the NT, same section, mid-sagittal section is for the ductus venosus also. Dr. Rishi Kumar, please concentrate on your plane. Your plane is not appropriate. That is why your ductus venosus will not come, and it will not come till you will not take a complete mid-sagittal section. So this was a brief explanation. I am very sorry, my explanation is very lengthy always, of Dr. Rishi Kumar's question. Now, where to go? Which Dr. Durgesh. Dr. Durgesh is our academic head who are working in BillMed. This is Dr. Durgesh, one of our candidates. So Dr. Durgesh is posting, sir, you said that yolk sac is diagnostic for intrauterine pregnancy, but in this picture it is ectopic. In which picture I will show? Now the confusion arises. Confusion is here. What the confusion is, I will first show you the picture where the confusion arises. So these are the questions. So let me go out from these questions now. Where is Shreya? What is WhatsApp? So the point here is that, is there any gynecologist or not a gynecologist, whosoever is doing a basic ultrasound scan, please raise your hand. I want to discuss this point, these cases rather one-to-one, rather being one-sided session. So let anybody raise the hand so that we can take interactive session. Dr. Vikas Singh has raised the hand. I am unmuting Vikas Singh. And one more candidate has raised the hand. I am sending unmute invitation to both of you. Please accept the unmute invitation and say hello.
Hello, sir.
Yeah, what is your name?
Dr. Vikas.
Dr. Vikas. Next.
Yes.
Hello.
Yeah, what is your name?
Dr. Shiv Kumar, sir.
Dr. Shiv Kumar. Please remember Dr. Shiv Kumar and Dr. Vikas. Okay. Now the question here is that I am trying to go to their WhatsApp so that I can show you the image. So till it gets downloaded from the server, I mean the case which we have got, let us discuss second part of the same question. The second part of the same question, not same question, the same candidate's question is that difference between ring sign, blob sign. What is a ring sign and what is blob sign? Dr. Vikas, next.
Yes,
Dr.
sir.
Shiv Kumar. Dr. Vikas or Dr. Shiv Kumar, what is a blob sign? In ectopic pregnancy, I mean, what is a blob sign?
A blob sign when a gestation sac is extra uterine, like in ectopic, para-ovarian, or in the tubal ectopic, it will show the blob signs.
What is a blob sign?
Blob sign is a thickness.
What?
Thickness of the gestation of the ectopic, because the
Can I
sac
say?
have...
Yeah, very good. Hold on. Now the point is, can I say that the blob sign is nothing but decidual reactions around a gestational sac? Which gestational sac? Ectopic gestational sac. Yes or no?
Yes, sir.
Yes,
sir.
So blob sign is nothing but a decidual reaction around the gestational sac, and right now we are talking of an ectopic gestational sac. Gestational sac, I told you in class also, and I'm again repeating, it is like a leech. Wherever it goes, it gets stuck over there, and wherever it stucks, it makes a contact. It tries to make a contact with the surrounding tissue wherever it implants, and that contact is being reflected on ultrasound screen as a decidual reaction. I will not draw on the board because we have already discussed and we are discussing in our courses. So blob sign is nothing but a decidual reaction around the gestational sac. Now, why Rishi Kumar? Why Dr. Rishi Kumar? No, Dr. Durgesh. Why Dr. Durgesh is confusing? Because he is thinking that ring sign is something else and the blob sign is something else. And what is a tubal ring sign? He is confusing between the terms. Please make a note that blob sign, tubal ring sign, and bagel sign, everything is same. So these are the different terms. These are the different terms used for the blob sign only. It means that whenever you are talking of a blob sign, tubal ring sign, bagel sign, everything is only one, and that is the so there is some technical glitch. So there is some technical glitch. I don't know. Let me see what happened. So the second part of the question is, let us fix the glitch first. Yes, now let me show you the case where the confusion arises. Now, let me go to that case. Yes, here it is. Now see to yourself, what was the name of the candidate, doctor? Dr. Shiv Kumar, are you there?
Yes, sir.
Dr. Vikas, there?
Yes, sir.
Now see, I showed in the course, this is the gestational sac in adnexa. This gestational sac is having a yolk sac. The doctor is getting confused over here. Dr. Durgesh is getting confused why there is a yolk sac in this extrauterine pregnancy. Always there can be a yolk sac in the gestational sac which is ectopic, but when we are talking of a pseudogestational sac which lies in the uterine cavity, there will not be a yolk sac. So don't get confused between a yolk sac which is in ectopic, which is in adnexa. Whenever I say there is no yolk sac, I mean in pseudogestational sac there is no yolk sac, because that is a pseudogestational sac. Now what is the Bagel sign? Now see the Bagel sign. As here I can see that there is a ring around this. This is a decidual reaction. This is globe sign. This is Bagel sign. This is tubal ring sign. What is here? This is a next circular, semicircular lesion over here. This is nothing but the corpus luteum, which we have discussed in the class. So the point here is that Bagel sign is nothing but the decidual reaction, and yolk sac can be in extrauterine, and it will be there in extrauterine gestational sac, but not in a pseudogestational sac. And the second part of the same candidate is posting, what is the pseudogestational sac? Please go to the course, and it will take you about 2 hours to understand what is a pseudogestational sac. Anyhow, pseudogestational sac is nothing but a fluid collection in the endometrial cavity. How will you expect a fluid collection, a pseudogestational sac, to have a yolk sac over there? So that was the confusion with this Dr. Durgesh, and he or she, I even don't know whether he is she or he. I am very sorry. So here the confusion arises. Now I got this case over here. This case has been posted by Dr. Pankaj Gupta. Liver and gallbladder, female, 56 years, pain in right upper quadrant from last 1 month, loss of appetite. What this can be? I am playing over here the same clip. Dr. Pankaj will tell me what this is. Dr. Pankaj, you there? Next. Dr. Shiv Kumar, you there?
Yes, sir.
Yeah, what is in this gallbladder?
That it is sludge.
I am playing it again. So first of all, what we are seeing over here, that there is some hyperechoic, I will not say hyperechoic, a mixed echo texture area in the gallbladder occupying almost whole of the lumen. This is sludge. Yes, very good. Now, sometimes this sludge, please make a note, sometimes this sludge can come at par with the liver echogenicity. I'm repeating. Sometime the echogenicity of this sludge will come at par with the echogenicity of the liver, and we can label that gallbladder as hepatization of gallbladder. Gallbladder looks like a liver. So this is nothing but a sludge over there, a diffuse sludge which is occupying whole of the lumen of the gallbladder. Very simple. It is a sludge. Very good, doctor. You hit it right. Now, the same picture, not same picture, the picture of this same case is also showing me, yes, this is a gallbladder sludge only. Now, sometimes the sludge will not occupy whole of the lumen. Doctor, name? Dr. Shiv Kumar, there?
Yes, sir.
Sometimes, if it will not, now imagine, if this gallbladder will not be filled by the sludge, but there will be some neck or maybe in the fundal part of the gallbladder which will have sludge, and that sludge is echogenic. What will that look like? Think. If whole of the gallbladder is not having the sludge and only some part is having a sludge, and that sludge is having more echogenicity, more dense, that is, what will that look like?
Partially
Others in
filled,
comment box, please post in comment box. Please post in comment box what that will look like. Comment box, Shreya, keep an eye on the comment box. Chat box, I mean comment box. Post your answers in chat box. Everybody, I am repeating, if there is a localized sludge and that sludge is having more density, and with more density it will have more echogenicity, what will that look like? Dr. Anil Singh, porcelain gallbladder, no. Dr. Swapnil, calculus, yes. Dr. Swapnil again posting, will look like a polyp. The others are posting now calculus, calculus, calculus. Yes, I am getting many calculi over here. That is why sometimes these calculi are overdiagnosed. And when surgeon is operating and he or she is taking the gallbladder out with the response that there was no calculus. Now, what to do to see whether I am dealing with a tumefactive, so that is tumefactive sludge. I mean a concentrated hard type sludge with more echogenicity, with more density from a calculus. The only point which will help me over here is the posterior shadow. Irrespective of having a tumefactive sludge, more density, I mean, it will never come with the density, it will never come to the density of a calculus. So if you are having a poor or a low, I mean low intensity shadow posterior to a calculus, ask yourself, am I dealing with a calculus or a tumefactive sludge? So the point is, we are concluding it, point is that if the posterior shadows are not strong, ask yourself why they are not strong. Believe me, ultrasound is all about why, and why. You have to ask yourself questions. For example, over here, why with this much of big calculus? Of course, a small calculus may not have a strong posterior shadow, but with a 10 millimeters or a 12 millimeters calculus, I should expect a good shadow, and all of a sudden I am seeing a big calculus with a very low intensity shadow. I have to think on lines of tumefactive sludge. Okay. Next case which has been posted over here is of abdominal ultrasound over here. This case has been posted by Dr. Swapnil. Case of epigastric pain since 1 month, vomiting 1 month, no history of fever. Please comment on altered echo texture in liver in 4th segment. Other findings include ascites and non-visualized right kidney. I am playing the clip for you. It is over here. I am seeing the pancreas. Now see, the pancreatic area is over here. The doctor is worried about some hypoechoic, I will not say hypoechoic straightforward, some altered echo texture which is arising near to the pancreas, and in between the pancreas, I will here, in between the pancreas and the liver. Please raise your hand to discuss this case with me. Dr. Now see, the people are entering here as iPhone. Whosoever is having this as a entry name and will get an invitation, please accept. Dr. Swapnil, I am also sending you the unmute invitation. Please make sure that there is no background noise. Dr. P. Yadav.
Hello, good evening, sir.
Yeah, good evening. Hold on. Remember the names. Dr. P. Yadav. Yeah, one by one. Say hello. Whosoever is unmuted.
Hello, sir. Good evening.
Yeah, good evening. What is your name?
Sir, this is Dr. Swapnil.
Dr. Swapnil. You are the person who has posted this case?
Yes, sir.
Very good. So now see, Dr. Swapnil, you are worried about this area over here. Am I thinking right? This one?
No, sir. No, sir.
Not this one?
Sir, this
Which
was
one?
what I was suspecting as a lymph node, but the area of liver adjacent to the gallbladder.
Tell
So that is,
me
probably
where the
cause-
confusion is. I am playing your clip. Tell me where the confusion is.
Sir,
This is
in the clip
pancreas.
later on.
This is splenic vein.
Later on.
This is the right lobe of liver. This is inferior vena cava. This is aorta. Where the confusion is.
So in the liver, later on in the clip, it will come.
Tell me, I will pause that. That
Okay, sir,
particular point, tell me where to.
Yes, sir. Yes, sir. This is the area.
This one?
is the lower decortation. Yes, sir.
Let me play this again.
So it was also confusing me as whether it is focal fatty infiltration like that. I was not able to diagnose it properly.
This one, no?
Yes, sir. There was cholelithasis also.
I could make out that there are cholelithasis also.
Yes, sir. These are the areas.
Got it. Here, no? Let me come back to this area. I will come back to this area. First of all, see to the this area. What do you think? What is here at the level of the pancreas?
Lymph node. That is a lymph node, sir.
That is a lymph node. This one, no?
Yes, sir.
What was the status of the CBD in this case? What was status of CBD?
So CBD was not dilated.
Not dilated. Sure, no? This patient was having any ascites?
Sir, no, sir.
No. And the age of the patient, do you remember?
Sir, I don't remember properly.
No,
Actually,
approx age, was it in 30s or 40s? Or a more elderly patient? Yes, no.
That was in about 35 or 40 years.
35, 40 years. Okay. Now concluding, 30, 40 years patient with a an altered ecotexture area next to gallbladder. Now see, next to gallbladder. Gallbladder is having some calculus over there. So the first point which I have to think of is that if it is next to gallbladder, the next to gallbladder area is very favorite for fatty infiltrations or fatty sparing. So first point which I have to think is that, is this an area of focal sparing? Because this is a hypoechoic area. Point number one. Point number second, this area, now see, this area, this fourth segment is wait, let me go to that clip. Over here. Now see, where I am right now.
Hospital well-being is na?
Where I am right now. Please stop talking in between. This is portal vein. So am I in deeper or in the superficial area of the liver?
So this is the deeper
one. So point number second, it is in the deeper level of the liver because I am right now cutting through the portal vein. So this area is very favorite for the fatty infiltrations or fatty sparing. So this can be a fact of this spared area, but don't straightway jump onto that. Now, if this is a suspected case of what you are thinking, maybe a malignant case, are you thinking on those lines?
Yes, but my first suspicion was focal sparing only.
Focal sparing, but don't straightly jump. Don't straightly jump. If this is a focal spared area, this one, if this is the focal speared area, and if you will put a color box over here, and you will see a vessel coming and going through this area, that will make you to label this area as 100% focal speared. And if a vessel is coming this way and there is a mass effect, then this cannot be a speared area. Have you put any color Doppler onto this area to see for any mass effect? Yes or no? Hurry up, Dr. Swapnil, hurry up.
Sir, I don't remember, sir. Actually, this.
You don't
this
remember?
video I
Okay,
posted.
this case is already gone. This is past. In future, whenever you are thinking all lines of this is looking like a focal speared area, but 100% I cannot say. I have to put a Doppler onto this area, and if I see any mass effect, then that is 101% suspected case. And if there is no mass effect, you know how to see for a mass effect. If there is no mass effect, then only I can label that as a focal speared area. Okay, anything else? Now this one. This is a this can be, now see, this can be a case of an area of a lymph node. But as this is adjacent to this pancreatic head, I have to think on lines of some suspected area. You know what I am talking of from the pancreatic head.
Yes, sir.
Yes. So now if this is more oval and does not take color, then it is lymph node. If it is more round, then less unlikely it will be a lymph node, and more it is going maybe pancreatic CA. I am not saying that this is pancreatic CA. I am giving you a DD.
Yes, sir.
Okay.
Sir, it was not
Anything
taking
else?
color. Sir, it was not taking color. I remember that.
This is the case. Now see, this is the case. This is the case where you are getting suspected whether to label this or that. The findings are going, I am concluding, the findings are going more in favor of a focal speared area, but with 100% I cannot say because I have to put a Doppler to see for any mass effect. How to see for any mass effect, you better know now. Anything else? So these were today's questions, which I showed you as it is. I have received on the WhatsApp. And in case you are having any more question, I am giving you an opportunity to raise your hand, and I will unmute you to discuss live if you are having any more question. Yeah, I am having one more question. Yeah, sorry. I am having one more question from Dr. Please mute yourself. Whosoever is unmuted, please mute yourself. Dr. P. Yadav, please mute. Dr. Swapnil and others, please mute yourself. Now I am having one question from a gynecologist. I know she is a gynecologist, but I even don't know her name. Why? Because the question is that how to take a peak systolic velocity of I'm showing you the question. How to see a peak systolic velocity of a follicle which is about to rupture. So she is dealing with IVFs, ARTs, I mean. And second part of the same question is that how to take the volume of the endometrial cavity, endometrial volume, not thickness, volume. So she is dealing with ARTs and she's a gynecologist. Any gynecologist over here? Any gynecologist, please raise the hand. Gynecologist only, whosoever is dealing with ARTs. Hurry up, gynecologist who is dealing with ARTs. Hurry up. Dr. Zainab.
Yes, sir.
Yeah. You are a gynecologist?
Yes, sir.
You are doing a basic ultrasound, yes or no?
Yes, sir.
A basic one you are doing, na?
Yes, sir.
Now, how to take a volume? Forget about the endometrial volume. I will come to endometrial volume. How to take a volume of anything? Anything means anything. Which dimensions do I need to take the volume of any organ?
So we take in two directions. First is the transverse and a vertical direction.
So you are saying that you are taking two dimensions to take the volume. Yes or no?
Three measurements are taken in two directions.
Very good. Very good. Now, not in two directions, in two sections.
Yes, sir, sorry.
Okay. So the point is, whenever I am taking volume of anything, anything means be it of this room, be it of my head, be it of the ovary, be it of anything, I need three measurements. Otherwise, whatever volume will come will not be the actual volume of that thing. What are the three measurements? Length, width, and depth. This is a detailed class in physics and machine settings, how to take a volume. Now, apply this on the uterus and tell me how to take a volume of endometrium, how to take. So it means that I have to take this dual image on your screen is not to save the paper. This is primarily meant for to take the volume. You have to put over here on the right side of the screen or on the left side screen the transverse section of the uterus. And on the other side, you have to take the long axis of the uterus. Then you take transverse, in transverse section, you have to take length, yes or no?
Yes, sir.
No.
So
I'm repeating.
transverse.
In transverse section, you have to take length, yes or no?
No, sir.
No, because I cannot take length in transverse section. Recall the physics and machine settings class. In transverse section, I can take width, yes or no?
Yes, sir.
Yes. So it is the width which has to be taken from transverse. Now come to the longitudinal section wala. What I can take in longitudinal section is first the length, yes or no?
Yes, sir.
Then where to take the depth? Third measurement is the depth. Where to take the depth, in longitudinal or in transverse?
So longitudinal only.
In both you can take.
Okay.
In both you can take, be it in longitudinal or in the transverse section. But usually we are taking it in longitudinal section. Then whatever volume will come will be the actual volume of the this endometrium. So this way you have to take the volume. Second part of the question is that how much should be the peak systolic velocity of the about to rupture follicle. About to rupture follicle, peak systolic velocity should be approx 10 centimeters per second. 10 centimeters per second. Now we are talking of Doppler. Whosoever has completed the Doppler will understand me what I mean by peak systolic velocity. It is not the RI, it is not the PI, it is not the S by D ratio, it is the peak of the systole. I have to see the scale and I have to see the peak of the wave, and if it is near to 10 centimeters per second, then that is about to rupture follicle. So this endometrial volume is 2.8. 2.8 plus minus 10%. So on an average, it is 2.8 milliliters, 2.8 milliliters. So it means that it is somewhere in the bracket of 2 to 2.5 milliliters. Any more question from anybody?
So I wanted to ask one question.
Yeah, what is your name?
Sir, Dr. Zainab.
Dr. Zainab, yeah.
Yeah. So sometimes we see that patient comes after taking the empty pill for the abortion. Now, when the pregnancy test is, they do pregnancy test and they come, they say that the pregnancy test is weakly positive. Now they come for transvaginal sonography. we do transvaginal sonography. Sometimes sometimes we are unable to differentiate between the retained products and the thickened endometrium. So, is there any?
I got it.
Yeah.
I will sum up your question and you will tell me whether I have got it right or not.
Okay.
Now, sometimes you are seeing a thickened endometrium and you are getting confused this thickened endometrium with something in endometrium, and that something may be a blood clot over there. Yes or no?
Yes, sir.
Yes. So the point here is that if everything has expelled out, now you will tell me, you will answer me, if everything has expelled out, how much will you expect the endometrium to be? Will you expect the endometrium to be the thick as it is in a luteal phase? Yes or no?
Yes,
when
sir.
everything has expelled out yesterday or maybe a day before yesterday, will you expect a luteal phase, thick endometrium? Yes or no?
No, sir. No, sir. We won't
No,
expect.
hold on. Will you expect a 12 millimeters or a 14 millimeters endometrium in that particular case where the patient has expelled out everything? Yes or no?
No, sir.
No. Will you expect even a 8 millimeters endometrium over there? Yes or no?
No, sir.
How much the endometrium should be if everything has expelled out?
It should be around 5 millimeters.
Very good. It means it has to be maybe less than 5.
Yes, sir.
Because in early stages, the endometrium is very thin. Now, all of a sudden, you are seeing a thick endometrium. In that case, in that particular case, whatever we are discussing, everything is expelled out. Will you expect a 10? No, you will not expect. So the point is, if the endometrium is thick, and try to understand, if endometrium is thick, it is not actually the endometrium which is thick. It is something in the endometrium which is making it a thick. Are you getting the point?
Yes, sir.
It means now there is a rule. If it is 10 or more, then there is a small blood clot over there or small multiple clots over there, which is making an impression of a thickened endometrium. So the endometrium has to be as thin as maybe 4 or 5 millimeters. If there is 10 millimeters or more, there is something in the endometrium which is not picked by your machine, but endometrium is yourself telling you, doctor, I am having something in me, that is why I am more bulky. Now, how to differentiate whether I am dealing with a blood clot in that endometrium or an RPOC? Second part of the question.
With the color flow,
With the color Doppler. Now, with the color Doppler, we will differentiate whether I am dealing with an RPOC or a blood clot. That is second part of the question. Third part of the question. These questions will make you understand. The third part of the question. You post me question. I posted you multiple questions. And the discussion of these multiple questions will make you understand. So now the second, this is not actually the question. This is the way when you are doing ultrasound, you have to pose these questions to yourself. Now, if there is a small RPOC, Dr. Zainab, your name, na?
yes, sir.
Dr. Zainab, try to understand this point. If there is a very small RPOC and that RPOC is as small as 2 or 3 millimeters only, what will be the net result of the endometrium? Will it be very thick?
No,
Yes
sir,
or no?
it won't be very
No. Now, try to understand my point. If you are having a 4 or 5 millimeters of endometrium and there is an RPOC, there are very high chances that you will miss that a small RPOC. Yes or no?
Yes, sir.
What to do to see for that small RPOC, which is not getting resolved by your machine because that is very small? Think
Color
first.
flow.
Very good. So always and always put a color in that case when you are thinking or your patient is telling, I have expelled everything. Put a color onto that endometrium, irrespective of that endometrium. If 4 millimeters, even 2 millimeters endometrium is showing you the color, and that to a bunch of color over there is making you to think, oh, there is RPOC, which is not getting visualized, but what I am seeing is the result of the RPOC, that is the high blood flow in a small area, in a given area over there. Where from this small, not small, where from this color flow is coming, that is actually the trophoblastic invasion. So it is the trophoblastic invasion which is making me to see the high color in the given endometrium, given point of the endometrium. Understood?
Yes, sir.
Dr. Zainab, clear?
Yes, sir. Thank you, sir.
Okay, welcome. So, any more questions from anybody? Okay, God bless all of you. So this was all about today's interactive session. See you next time when we will announce in your groups. So we are connected via our WhatsApp groups. We are having 10-15 WhatsApp groups where we are having money ongoing candidates, and everybody of you are added in some of these groups, and you will get an update. And most probably next week we will be taking one more interactive session. So what you have to do, you have to send your cases on our helpline number, and that is 4 times 9 34 72 42. I am repeating, 4 times 9 9999 34 72 42, which you know is our helpline number. You have to post your questions onto that helpline number, and we will take that and discussed as discussed today. We will discuss next week. But request, what the request is, don't post any question from any topic which you have not touched on our server. So please try to complete the topic first. For example, you are enrolled for a gynecological, complete gynae ultrasound. First, physics and machine settings. You complete that, or you are somewhere in the midway, you can post. But being in the physics and machine settings, you cannot post a question of a color Doppler or a fetal echo, because you have not even touched that course. So the request is that don't post the questions from that course which you have not touched yet. I mean the sub course which you have not touched yet. At least you have to start that topic, then you have to post that, because unnecessary will be posting the questions only, and every question's reply will be there in your course. So complete your course, not even complete, touch the course, and whenever you feel any question is getting raised over there, we are here to help you out. Thank you very much.